Welcome to another episode of DxTx Partners Podcast. And I am very excited to have Dr. Jordan Tate with us today. Dr. Tate is the Chief Medical Officer at Southern Pain and Spine in Georgia. She's also a founding member and board member of the Society for Women Innovators in Pain Management. In addition, she's a Vice President of Diversity and Outreach with the American Society of Pain and Neuroscience, VP and board member of the Georgia Society of Interventional Pain Physicians, as well as an accomplished researcher, director of several research projects in spinal cord stimulation. Dr. Tate, impressive resume there. Where are you joining us from today?
Hi, Mike. Yeah, I'm in Jasper, Georgia, at my Southern Pain and Spine office, and excited to be on your podcast. Thanks for having
Awesome.
me. Yeah.
Yeah, we're really excited to have you. Can you walk us through just kind of your journey from, I know Vanderbilt, Mayo Clinic, Emory, some really impressive educational background. Kind of walk us through what got you into the pain management space.
For sure. It's actually an interesting story. I'll give you the abbreviated version. I always thought I wanted to be a doctor. It's the only thing I ever wanted to do. And then I really thought I was going to be a pediatrician, as a lot of young people who want to go into medicine want, because it was my experience. And I went to med school, went to Emory for med school, thinking I was definitely doing pediatrics. I remember other people saying, I'm undecided or I don't know, I'm going to wait and see. And I was like, wow, that's so crazy. I'm going to be a pediatrician 100%. And then I did my pediatrics rotation and I really didn't love it. And it really broke my heart working with a lot of the sick babies and just different things like that. And it really wasn't where my passion was ultimately. And so I became one of those kind of lost souls that was like, well, what do I like? What excites me about medicine? What do I enjoy? And I realized that I really love the idea of diagnosing people. I love spending time with people. I love being part of their journey and their story. I love the idea of being able to help them quickly. And so a lot of these kind of things started lining up. And one of my was a vascular surgeon said, there's this field I heard of. One of my friends is doing it. It's called physical medicine and rehabilitation. I don't know if you've heard of it, but he's the happiest doctor I know. And he's like, and take it from me, I'm a vascular surgeon. I work at the VA and I am probably the most miserable doctor I know. And I was like, oh, okay, well, interesting. Let me learn about PM&R. And so I just went, to Google and Googled it, and I found the local Emory PM&R residency. And, even as a med student, we'd never heard of it. There was no PM&R interest club, or really the word was not out. A lot of people say it's the best kept secret. And so I just kind of cold called the pain doctor that was also the PM&R fellowship director or residency director and, said, can I meet with you? And as I'm, setting up this meeting, I get a call from my older brother, and he says, I'm having this back pain. And my older brother took a different path in life than I did. He didn't go to college, and he was working, kind of odd jobs and different things like that. And he just, gives a vibe as like a, younger guy that wasn't really being taken seriously. And so he would go to primary care and he would go to urgent care and he would complain of this back pain. And everybody was writing him off as a drug seeker. They were all like, this 25-year-old guy, he's got tattoos, whatever, just very much stereotyping him and saying he's a drug seeker. And so meanwhile, I'm getting this appointment to meet with the PM&R director, and he's telling me, PM&R and then pain medicine, it's the best trajectory you're ever going to want to take. You'll never regret it. It's a great lifestyle, all this kind of stuff. You get to help people. It's really fun and interesting. It's super dynamic. It's going to be the future, all this kind of stuff. So I'm hearing this, and then I'm kind of following along my older brother's journey, and he ends up going to see a neurologist who takes one look at him and says, has anybody ever told you that you have neurofibromatosis? And he was like, no, neuro what? What's that? Right. And so he immediately was like, you have all of the classic findings on physical exam. It's wild to me that you've been seeing all these doctors. Meanwhile, I'm a med student, but I was so busy, I was like hardly ever seeing my brother anyway, right? But anyway, nonetheless, it was like, oh wow, everybody's missed this diagnosis. And so he immediately gets an MRI and he needs to have urgent decompressive surgery because he has a spinal tumor that was causing his back pain.
Oh,
Yeah.
wow.
And so, but that really resonated with me because it was like people go to the doctor because they're suffering, because they're in pain, because they need help, right? And he was trying to get help and he was explaining himself, and everybody was just writing him off. And they were, he's this kind of marginalized patient that was being, mistreated and misdiagnosed. And this went on, for months before he finally got a diagnosis and got the surgery he needed. And, I mean, besides his night he spent in the hospital, he never took an opiate, by the way, right? Like, I mean, nobody ever would ever, they would never give him pain medicine. He never asked for pain medicine, right? All he wanted was a diagnosis. But it really resonated with me that, there's a lot of people in society that feel this way. There's a lot of patients that feel misunderstood, that aren't being given a chance, who are being written off. It also kind of just interested me in this whole idea of like drug seeking. What does that really mean? When somebody's asking you for help and they're asking you for a medication that they think will help, what is this whole field of pain medicine? And I wanted to explore it more. And so that was really what like sparked my interest and gave me a lot of passion for our patients who have chronic low back pain.
Wow, that's fascinating. Something that you said that kind of really resonates too with, I think, what probably separates a lot of the top doctors is not just the science that you know, it's the empathy, it's the listening, and that piece of it really came through. So that's a very interesting story. So you have your hands on a lot of stuff. How do you balance like clinical practice, your research, your leadership roles without losing sight of the patient care that drew you to this field?
Yeah. I mean, at the heart of everything we do are the patients, right? Like none of this is, it's not worth doing research. It's not worth, you know, um, running a clinic or, really endeavoring in any of these different forays, if not for the fact that I love patients, I love patient care, and I put it at the forefront of everything I do. Our entire motto at Southern Pain is about patient centricity and making the patients our central focus. So we call it patient-centric care with a Southern hospitality flair. So that's our cute little motto. So at the beginning and the end of every day, I'm thinking about how do I construct my day so that I can be there for my patients, so that I can show up, be the best doctor I can be. As a private practice owner and, clinic owner, I'm always thinking, how can I give the patients the best experience so that they're, spending less time in the waiting room, getting their procedures in an efficient and safe way. And so a lot of these things I have a lot of passion for, and I really love educating, and I love to get other people excited about that. And so, my engagement in society, a lot of it, the societies that I'm part of, a lot of it is just, my opportunity to share that passion and share my experiences and help really foster better experiences for other people's patients, right? Like if I'm teaching a young physician how to do the mild procedure, I mean, I love the fact that I can do the mild procedure on 50 patients a year, and a lot of them are going to do so, so much better, and that's awesome. But I really love the fact that I can go to a lab and I can train 20 physicians on a weekend, and then they can go out and do the mild procedure on 50 patients, right? And so, you just exponentially are helping people, with a farther reach. And so, to me, I get a lot of personal satisfaction from that, a lot of enjoyment from that. I feel like, it's my ability to put my stamp on the world and to help as many people as possible. So, balancing it all it's never easy. People are always like, you must not sleep, right? How do you do all this? You must not sleep. And it's actually quite the opposite. I prioritize sleep. I prioritize time with my family. I prioritize self-care. I have my Sunday self-care rituals. I have my morning meditation. I make sure that I'm calling friends on the way to and from networking dinners and touching base with people, having good laughter and, other decompressive strategies so that life isn't all about work, but it's all about making work fun so that it doesn't feel like work.
Wow. And have incredible time management too, because there are so many hours in a day,
Yeah.
regardless, and the amount of
Yeah,
things.
I mean, it is something that I feel like I've always excelled at, like being able to kind of multitask and do a lot of things at once. But I mean, when it comes to multitasking, I really think, it's never really true multitasking. It's
Mhm.
compartmentalizing and it's prioritizing. I think it's what is urgent and needs my attention right now. I focus on that, right? And a lot of times that is patient care. A lot of times it is being a mom. And then, some of these other things that I have on my list, they may need my attention, but maybe they have less urgency. Or, maybe something is more urgent right now, but it doesn't really need me. It's something I can delegate to somebody else, right? And so I think all of these kind of strategies that busy multitasking people do. It comes naturally in a way, but really it is actually a thoughtful, intentional process.
Very neat, very neat. Um, you're obviously very well known nationally, and as a national thought leader, what challenges have you faced breaking down barriers in a mostly male-dominated field?
Yeah, I mean, when I came out of fellowship in 2014 and I started attending conferences or, showing interest that I wanted to get involved in research. There weren't really a ton of opportunities. There were some role models, like Andrea Trescott and people like her that are just amazing role models for me. And having that representation and that, ability to say, I could do that and I can be there. And really, a lot of it was approaching people and saying, how did you get there? What are your recommendations? What are your pearls? That kind of thing. And so, it's less about like aggressively trying to break down barriers and more about how to be the best authentic self with an organic growth that, allows you to shine and be present and show up. I mean, I think that's so much of it, right? Like Kaz Amerdelphin is a great mentor of mine. And I went to the INS conference in Scotland in 2017. And I sat down with him and I was like, yeah, I mean, how did you build this like research empire? And like, how do I get there? And all this kind of stuff, and he was like, I mean, you're doing it. It's showing up. It's showing up and being present, being, engaged, asking for opportunities, creating opportunities for other people, all of that. And so, I mean, a lot of it has to do with research as well. I think, one of my big passions is seeing more women on the podium, seeing more women's names published in papers, getting more women to be higher up in on the PubMed section with all the paragraph of names and really trying to get more women to be the PIs of these research projects and things like that. And, and that's really where like the creation of WIPM, WIPM, Women Innovators in Pain Medicine. And so, we came together in 2019 in Coeur d'Alene, Idaho. Dr. Jessica Jameson just, thought it would be fun and impactful to get women in our field together and have, kind of throw a small conference and educational symposium. At that time, it was just like, Women's Pain Conference, I think she called it, or something sort of, generic like that. And I mean, I wasn't even able to attend because I had just had my third child, my little girl. And so I was actually at home in here in Jasper, and they put me on the agenda to give a talk on the history of spinal cord stimulation. So they zoomed me in while I was on my back porch on maternity leave, breastfeeding my daughter, and I'm giving this talk on spinal cord stimulation to, like a small crowd of women. There's like 35 of them in the room. And from that small conference, this idea came together, let's turn this into something more impactful. Let's create a society. Let's move the needle forward. Because, at that time, there was a well-known study that looked at the percent of women that are interventional pain doctors. At that time, it was 18%. It was actually just redone by the AMA and published yesterday. We are now up to 24%. And
Oh.
which is exciting. We're moving,
Yeah.
we're growing, but it's still a very male-dominated field, and for a lot of different reasons. And and there's a lot of reasons why it will never be 50-50, I'm sure. But making sure that the women that are in our field are granted the same opportunities, are having a seat at the table, having opportunities to be involved in research if that's what they desire to do, to be able to present their abstracts and be at the podium, and just trying to explode that 24% to make sure that we're really shining as bright as we can.
Very neat. You mentioned Andrea Trescott. I actually know her pretty well. And a funny story, I've been in interventional pain management, not a physician, but I've been in interventional pain management since 2017. And the first time I saw her speak, I was just blown away. And I had no idea what she was talking about. It was just so over my head. And I turned to the physician next to me and I'm like, that went way over my head. I have no idea what she just said. And he's like, I didn't either. So it made me feel a little better. She is so smart and so impressive.
She
Um,
is. She is.
yeah,
She's quite a force. And, I was kind of drawing a blank for whatever reason, trying to think of Lisa Stearns is also an amazing role model. And both Andrea and Lisa, Dr. Stearns and Dr. Trescott, were both founding members of WIPM as well. They were on the board. So,
very, very neat. So I have a daughter who is in the middle of her third year of medical school right now and trying to figure out which way she's going to go. And just very similar to you, sort of what she thought she was interested in coming into med school. Now that she's going through these rotations in her third year, she's starting to eliminate some things. But what she's very interested in is PM&R and is hoping that she can potentially match in PM&R residency. What advice would you give to young women like my daughter who are going to end up potentially in one of the interventional specialties?
yeah, I mean, I think, there's a lot of opportunity. There's a lot of opportunity for growth. I think PM&R is an amazing field. And then, going into pain is a path as well, because you do get to check a lot of boxes. You get to have a, deep and impactful relationship with your patients. I mean, many of our chronic pain patients, as much as we would love to treat them with one epidural and then see them never, that happens sometimes, but a lot of times there's a lot of longevity with these relationships. And so I think, that's something that is really amazing that you can't necessarily get anywhere else. But you also do have the opportunity to kind of cultivate your own practice. If you're interested in getting into more advanced, minimally invasive spine and really cutting edge technologies, that opportunity is there. If you're looking more for something that might give you maybe a little bit more of a well balanced, outpatient experience where you're doing, more spine injections or Botox or EMGs, things like that, with general physiatry practice, that's great opportunity as well. There are some local women's physiatry groups that potentially she could be a part of. I know like in Atlanta, we have one specifically as well. And so I mean, I encourage her to go into PM&R. I think it's a great field. There's a lot of, different pathways after residency, sports medicine, brain injury,
Mm.
spinal cord injury, and, a lot of exciting technology that's coming out of the spinal cord injury space, for example. So, but if she's interested in pain, for sure she should come to WIPM in June and, get in on one of our female, all women taught cadaver labs. It's all female faculty, all female attendees. And it's just the best environment for young women to really be able to, ask their questions and have a safe space and feel comfortable, in an otherwise intimidating environment.
Yeah, she'll be all over that. I guarantee you she'll love to attend. The story of your brother was amazing, but just in the last few years, you need to see the way the field's transforming. Do you have any other cases or patient stories of some of the transformational interventional techniques that you've used to have a great outcome?
Yeah, of course. I think the first person that always pops into my head is one of my patients who, as part of my kind of chronic pelvic pain practice that I have, I sort of have this subclinical, like practice with chronic pelvic pain. So it constitutes about 15 or so percent of my patient population. And the opportunities for treatment for chronic pelvic pain is minimal in the sense that insurance coverage for things, a lot of our treatment options that are evidence-based and do have amazing outcomes and are safe and effective have been declared experimental. And it can be really challenging in an interventional pain practice to really help chronic pelvic pain patients. And by the time they get to us, these patients have already seen urology, gynecology, GI, primary care, of course, physical therapy, and the list goes on, And so a lot of times they're extremely refractory. And so I always think of one patient in particular. She came to see me after her 13th abdominal surgery for
Wow.
advanced stage endometriosis. And, she was young, just in her late 20s, and she had already had a total hysterectomy. And so she was, unfortunately never going to be able to carry her own child. And, it had really spent her late teen years and her 20s, basically as being, medicalized and all these kinds of, doctor's appointments and all this stuff. And so, she still living at home with her parents and, had never really had a, job, was unable to finish college, and just really in kind of a desperate way. And she had seen another pain doctor who, had treated her, with opiates because they really couldn't get anything else approved and they weren't working. And, it was just kind of making her more depressed and miserable and, constipated, which is not helpful for chronic pelvic pain and, all this kind of stuff. And so we worked really hard with her and her insurance and, really tried to get all these injections and things done. And over time, we were successful at winning appeals and peer-to-peers and, just really like went in the trenches and then battle with her to get things done. And, over time, we were able to make her a lot better and get her off some pain medicines and all of that kind of stuff. But it really wasn't until we went forward with a DRG trial and a DRG implant where her life completely changed. She went from, the severe pain, laying in bed all the time, all this failure to launch, kind of just poor quality of life and everything. And I mean, essentially, she's 3 years out from her implant now. She still comes to see us every 6 months to get a muscle relaxer, but she is completely opiate free. She has lost about 150 pounds. She's moved out of her parents' house. She's
Wow.
gone back to college. She's getting her social work degree. Her main mission in life, she wants to be a chronic pain warrior and like an advocate for people in chronic pain. And she just absolutely loves her DRG stimulator. And it's really just, revolutionized this entire young girl's life that, everybody else had kind of given up on. I mean, everyone was shrugging their shoulders. There's nothing else we can do, all that kind of stuff. And, I think, she had gotten to the point where she probably had a lot of distrust in the medical system, had lost a lot of faith. People saying, let's try this, let's try that. That doesn't work. You after that happens to you 20 times, you kind of give up. And so I think we had mentioned, like stimulation kind of early on, and she just wasn't here for it. And it really wasn't until, we spent the time to, go to battle with her insurance company and get things approved and show her that we were, we cared about her future as much as she did, right? And, to have somebody in your corner like that and then to be able to ultimately get a life-saving treatment, that's why we do what we do. So
That's amazing. That is so awesome to hear that. And no matter what, AI can't replace that.
that's
So
right. Exactly. Exactly right.
replace that is so cool.
100%.
That's
Yeah.
why I love hearing that. Being at the forefront of our field, you get exposed to a lot of the cutting edge research. You work a lot with industry that are developing these products. What has you kind of most excited in the next 3 to 5 years in our field?
Yeah. I mean, I think one of the things that we're doing research with right now is an intradiscal therapy, and there are several more that are coming out that are going to be part of the research landscape and hopefully eventually part of, our armamentarium against chronic low back pain. But, I really believe that, a lot of what we see, right, is this degenerative cascade. And we get our patients in their 70s, and, now the arthritis is severe and the stenosis is moderate to severe, and, the multi-level disc degeneration, right? But I mean, where would we be if we could get to our patients that are in their 20s and 30s when they first start having this episodic back pain and they keep throwing their back out, and somebody says, "Yeah, you got a couple bad discs in your back. You're just gonna have to live with it for a while." Because, I mean, you try physical therapy and you strengthen their core and you teach them how to stretch I mean, there's lifestyle management things that you can do, of course. But, from an interventional standpoint, you try an epidural, you try some RFAs. They usually work like mid, right? When you're talking about discogenic back pain, which is why for some subset of those patients, a BVNA or basovertebral nerve ablation is an exciting new option that we didn't have before. But again, that's only for patients that have modic changes on their MRI and only for a subset of them that have insurance coverage, right? And so we're still only scratching the surface at, this large swath of our population that have this discogenic vertebrogenic back pain. And I really think that that's where it all starts, right? And so it's kind of like the unicorn of low back pain. If we can capture that, if we could treat that early, we could prevent this lifetime of disability and this lifetime of degenerative cascade and where everybody is going. And so I think that's really exciting. So injecting, there's couple of different, materials out there, biologics, cadaveric specimens, like just different ideas. Everybody's kind of coming at it from a different way. And so it'll be interesting to see, where the research ultimately leads us. Like I was part of a study with Viadisc with nucleus pulposus, which is a cadaveric allograft, and injecting that. And I mean, patients do great. And, unfortunately for that study, we had to really limit ourselves to our Medicare population, right? Because that's what it was covered for. And so, I mean, it's interesting because a lot of people think, well, somebody's in their 70s and 80s, multi-level disc degeneration, doing a single allograft injection isn't going to make a big difference. But we actually saw about a 60% reduction in VAS and ODI. And so the patients actually did really well, even though they were extremely difficult to treat kind of population. And so if we could actually apply, that therapy to our younger population, we would, really be seeing, I think, even, more improved outcomes. And we're also working right now with like a hydrophil study, which is basically a polymer that we inject. And that, I mean, it goes in as like a liquid through the needle and then puffs up essentially and becomes like a liquid disc replacement. And
Wow.
so, right. And so, I mean, just exciting stuff that, if we can get this through all the research and really make this readily available as a safe and effective treatment. And you could fix, a lifetime of potential chronic low back pain by, injecting and fixing a disc with just a needle puncture. Like that's what gets me really excited about participating in research.
That's really cool. I asked that question to a lot of people on the Partners podcast, but that is not a lot of new stuff. That's some stuff that I haven't heard at all. That's really, really neat. With the research, the teaching, the leadership, the patient care, the ownership, the CMO, the training. I know in your practice you have, three or four really young new physicians that take that mentoring and work. You touched on it a little bit earlier, but can you expand a little bit on how the energy and the passion comes through very clearly. How do you recharge? How do you maintain that? What do you do to kind of refill your cup?
Yeah, I mean, I have three kids, so my full-time job doesn't end when I clock out. So, going home and attending all of their sports games and cheering them on from the sidelines. My kids are really involved in a lot of different activities Not surprising. It's a genetic problem. But my older son, he's in high school, he's in ninth grade, he's on the lacrosse team and the swim team, and he does competitive downhill mountain biking. He also
Wow.
does 4-H. And so there's a lot of different competitions. And then my younger son is on a travel soccer team. And then my daughter, she's 6, but she's gotten into dance and soccer and things like that. And so I find that actually does recharge my battery. I know some people think of it as like just another thing to add to their list of what they need to do. And, unless they're alone in solitude, they're not recharging. But I find, that also that fills my cup. That makes me excited to be doing something different, to checking different boxes. It allows my brain, time to rest, or I'm not, putting together an academic paper or teaching somebody about policies on urine drug testing or something like that, right? And so that is recharge. We definitely love to travel, so I make sure to take the kids on several vacations, and my husband and I will get away. So, I mean, this year I've been to Mexico, Amsterdam. I went to the ISPN conference in London, but I decided to bring my whole family over. So we spent a week in London and then heading over to do a kyphoplasty lab in Vienna next weekend. But, I was like, great opportunity to take my husband with me and go see some of the Christmas markets. So I think that is how I decompress, even though it might sound like even more chaos and more things to do and plan for, but I enjoy it.
Awesome. Dr. Jordan Tate, thank you so much for
Mike.
highlighting your career, what you're doing to the people at DxTx, and we're glad to be partnering with you and really look forward to watching what you do. Fantastic. Thank you for joining us.
Thanks, Mike. Thanks for having me on. Such an honor.